retake your seats. We'll get started again. Okay. Tony will keep us on track.
Okay, thank you. We did find some errant slides, so Sherry asked me if I would go through them. There are our Santa Ana Dialysis Center. So as Sherry had mentioned, basically our sister Elizabeth Outpatient Dialysis Center was full. We were actually, facilities over 25 years old and needs some remodeling. Our patient population kept on growing. As I mentioned earlier, we had a lot of growth, 8% in Southern California. Our flexibility in scheduling patients' needs and for rehabilitation was compromised. And so we took a look at building this new facility. Let me just say it was a construction job from hell. I've over the years have built probably about 150 facilities, and this was the longest, most drawn-out one I have ever done. I actually started booking revenue and expenses in April of 2006, and we opened in 2009. That'll tell you how long and how delayed it was. Simple things such as, you can see it here. The reason we have this big trench here, as they were putting in the new drain lines for the dialysis stations, tapping into the main drain, they realized the main drain was no longer there. It had rusted out. So the entire building main drain had to be replaced. That delayed us a few months. And there was just all sorts of other things, but we do have a very beautiful new facility. Located 4th and Tustin in Santa Ana. It's part of the St. Joseph's Heritage Medical Building, the first floor. And our first patients that were transferred from Sister Elizabeth. I don't know, Sherry, do you want to make any comments about them?
Jackie, over on the right, is one of our oldest patient, longest patient in dialysis. I think she's 25 years in dialysis. So, and also Dr. Chen, he's a dentist, and Diane Nelson. So, we borrowed 3 patients from Sister Elizabeth, and they're still dialyzing right now in Santa Ana. So.
Old dialysis patients have been on for a long time. Usually are those that are a little persnickety. You're not supposed to eat chocolate when you're on dialysis, but several years ago I was working for Amgen as a manager of public policy and reimbursement for Epogen. And during that time, I was going back from Thousand Oaks, California, to Detroit, where I grew up, going to a dialysis unit there that I used to work at. As the last place I worked as a floor tech. I'm not going to tell you how many years ago it was. And I went there. I had an intern from Harvard who was doing an internship with me during the summer, and so she went to Detroit with me for a lecture, and went into the dialysis unit. And one of the dialysis patients that I knew from years ago, I found out she was still dialyzing there. At that point, she had been on dialysis 36 years. She went through a chair at me, so real feisty. And so I went up to her and said, how are you doing? And she said, looks up and says, damn, you've gotten gray. So, the patients keep you in line. Let's just put it that way sometimes. 30 stations, operations. We started in August 2009. One of the things that Medicare requires is that you have to dialyze patients for free for a while. So we dialyzed patients for free until we received our Medicare certification in 2009. We have been waiting and waiting and waiting. We put our paperwork in back in 2008 to get certified. Medical director is Dr. Michael Rutten. We have Sherry as our nurse manager. Cynthia is our clinical educator, supports all of our different renal areas, tech support, IS support, advanced practice nurses, dietitians, and social work. And it's really, again, a multidisciplinary team. We really try and get together to bring that. Individual TVs, we do have an isolation room, wireless internet, blood volume monitors, electronic medical records, and Sherry said she's over 70. One of the things that is amazing to me, I don't know if it's just because this unit took so long to dialyze or to open, is that we've had 8 patients recover renal function. I've been working in dialysis 30 plus years. I haven't seen 8 in 30 years. So I don't know if we just are doing something right or the water's really good there. I don't know. And there's a team in Santa Ana. state-of-the-art conference room, and I thought this was kind of telling. Dealing with difficult patients was on the screen at that point. And so this is some of our different areas. We have a in-floor weighing scale, as we do at Sister Elizabeth, patient drop-off, entrance, and really we tried to make the place warm and inviting. Use a lot of wood tones, a lot of softer tones that make it a little more comfortable for the patients. This is actually the entrance off of First Street. We have this monstrosity of a parking structure that the city of Santa Ana required us to build. I think it'll hold 265 cars. So we spent millions of dollars on a nice parking structure. Our waiting room, in-floor scale. So you can see the unit. Basically, the nurses' station is in the center of the unit. It allows for good traffic flow. And one of the things I like building units like this, because with the nurses' station in the center, even if there's two nurses there talking to each other, when they turn around to talk to each other, they still see patients. And so it's good visibility. Centralized med area. Okay, I'm going to turn this over to Kathy and talk about home dialysis.
Good morning, everybody. I'm Kathy Wilson-Bates, and I'm the Home Dialysis Services Coordinator. I guess I'd like to ask everybody just a quick question for those of you I know that work in the dialysis unit or in transplant, but for those that are in the room that don't work in those departments, how many of you have ever been over to the dialysis unit? Just raise your hands. So maybe half. Great. Part of my goal today is to hopefully pique your curiosity so that the others that have not been there might want to go over and just take a look in person and up close about what we do. So thank you for coming today. I'd like to give you the history that was relayed to me by Mary McKenzie. Most of you might remember Mary, and she gives an interesting perspective of our history of how we actually came to do dialysis in general. There was a priest freak accident that created an interest in the need for renal services. He was on vacation in the East Coast, and he fell while in a sporting goods store down an open elevator shaft many, many, many years ago, fractured his pelvis and multiple other bones, and could not return home because during that illness, he ended up with renal failure. So when he did return home, he met with Drs. Dom Gentile, Dr. Miller, and they were asked to pioneer the nephrology services at St. Joseph Hospital, along with the support of Sister Ann and Father Nee. It's been well over 37 years by now, but I thought that was an interesting little bit of history. So when we first started, we consider the Camelot years. Our first patient on home hemodialysis was a contractor from Hughes Aircraft, and that was in June of 1971, very long time ago. At that time, there was no funding for dialysis. So his employer created a charitable fund that is still in existence today to help pay for his dialysis services. In the early days, all dialysis units were hospital-based. At the same time, our services extended to the children in need as well. And I'd like to draw your attention to the hospital-based part, because nowadays you can pretty much drive, well, depending on how populated the area is, a mile in either direction, you might see a dialysis unit in a grocery store, shopping center. So they're really everywhere. This facility is really quite unique. I say that a lot while I talk to people, even in the hospital, that we don't quite fit in because we are so different. So St. Joseph Home Dialysis Services, our census as of this February, our pediatric peritoneal dialysis population, we're up to 9. I don't know if you could see the slide that Tony originally had earlier. That was maybe from a year ago. We were at 7, now we're at 9. Adult peritoneal dialysis, I think, was at 14, and now we're 16. Adult home hemodialysis, I remember that slide was 9, we're now at 11. When I first came to St. Joseph Hospital I think I'm starting my 7th year in June of this year, I think there are about 16 or 17 total patients. Our census has peaked at about 40, and that was almost 2 years ago in November. We lost almost 9 patients in 1 month, 3 that moved out of state, 3 that were transplanted, 1 that went in center to hemodialysis, and I believe 2 that passed away. Doesn't happen that often, but it does happen. So our census is very flux. Our goal, like Pam, with the children is so that they get a kidney. Our adult, same goal. If they're interested, they desire, and they can do the workup, we'd like them to get a kidney also. So some of you work in the hospital might not understand, well, what does it take to be a home dialysis patient? Does every patient qualify? Well, the patients are referred to us in many ways, usually by physician. Some do self-referral. There's always that kind of patient that seeks out information on the internet. And then they'll try to find, well, where can I do this procedure that I want, that I've looked into? And we'll get that, phone call. Oh, I read about you and blah, blah, blah. And then that starts the conversation. But also our technicians, our nurses, they work in other facilities. Most dialysis units are 12-hour shifts for nurses. Our unit for home dialysis is Monday through Friday, 8 hours. A lot of our technicians work 2 jobs. So they might refer patients also. And other facility staff. But the referrals come in a variety of ways. So more about our candidacy. Patients must have a training partner to perform home hemodialysis. I guess I want to make this really clear. The patients do this at home. We just teach them, but they go home and perform hemodialysis with the blood and peritoneal dialysis using the abdominal cavity at home by themselves. They sign our letter of program expectations, which says that we have to hear from you. When we put a call to your house, you have to call us back within 24 hours. Occasionally, if we don't hear from the patient and I'm concerned, we'll send a police cruiser just to do a safety check on the patient. So they have to agree to return our phone calls. And you'd think that, well, most patients would return your phone calls, but we do talk to our patients an awful lot, and sometimes they don't always follow the rules. But now we have a letter that they have to sign saying that they have to return our calls. They have to submit our treatment records. We need to see them at the end of every treatment. Tony alluded to the conditions for coverage and a lot of the expectations that we are held accountable for. This is one of them. We have to see their treatment records so that we can submit our billing that's correct. We don't want to submit billing to say they dialyzed on Tuesday the 3rd when really they dialyzed on Tuesday the 5th, because if we submit something incorrectly, we could be accused of fraud, and we're very particular about how our billing gets submitted. They must see the St. Joseph Hospital nephrologist monthly. No ifs, ands, or buts. That's part of the Medicare guidelines. But the last thing on the list is an acceptable environment of care. And I could talk for probably 2 hours just on this topic alone. Most of you, most of us, we go home to a nice, cozy, warm bed at night. The furnace might be on. There's food in the refrigerator. Maybe we had a meal at the kitchen table. And then we take a shower and we wash our hair and we prepare for bed. In the 6 years that I've been here, there have been at least 2 occasions where, at least 2, probably closer to 4, where I had the unfortunate opportunity to tell a person, patient, mother, father, that their home was not acceptable because they didn't have plumbing, or they didn't have electricity, or they didn't have, a way in which they could wash their hands. You wouldn't think in this day and age, in the area that we live in and the people that we serve, that this would be an issue, but I'm here to tell you right now it is. Just this last week, we had a patient transferred to our facility, and again, our hospital-based facility, we have all these regulations that we need to uphold to, and he had been dialyzing at another facility for about 8-9 months. Well, one thing I can speak from my heart and 100% certainty is I'm so glad I work here rather than a for-profit agency, because we really uphold the letter of the law quite literally. We have an incredible team of people that go out and evaluate just about everything, and part of our requirement is to evaluate the electrical safety in the home. It's not just the plumbing, but it's the electrical. So for peritoneal dialysis and hemodialysis, both require technical services such as, I don't know if any of you know Danilo Concepcion or Daryl or Octavio, and now we have Jay. They've been with us forever, 30 plus years, with the exception of Jay. I don't know how many years he's been here, but they go out and they check the electrical stability in the home. This young person came to us from another facility, and a plug had never been checked. So as it turned out, the plug wasn't grounded. You have to have a grounded plug in order to perform dialysis at home, because the risk of electrocution is quite severe should anything wet come into contact with the plug. So this was a first for me. I had to tell them they had could no longer perform therapy in their home using an electrical device. We had to convert them to manual exchanges. But we take this very seriously because the surveyors will come and they will look and they will want to know our documentation and make sure that our ducks are in a row. So acceptable environment of care, again, I could talk forever on that. It's not that we're going to do the white glove test to see if the house is clean. We want to make sure that they have adequate space to store their solution, that there aren't animals ranging everywhere. They can have dogs and cats, of course, but mostly it's, do they have adequate plumbing? Do they have access to a toilet? And what about the electricity? So training for home hemodialysis. Home hemodialysis can take anywhere, the training can take anywhere from about 5 to 9 weeks. It depends on their access and the type of machine that they've selected for home. There are 2 types of hemodialysis machines presently on the market. One is the standard Fresenius, it's called a K-at-home machine, but it also requires the water system, very much like in acute dialysis services. So the patient has the hemodialysis machine plus the water system. And there requires some maintenance generally to the plumbing and the electrical. They have to have a dedicated outlet for the machine, but also they have to have a dedicated water supply. And again, one of the wonderful things about working here is St. Joseph Hospital will evaluate a patient for candidacy, and they will invest the money to fix the plumbing and to fix the plug. If they were in the for-profit arena, I guarantee you that would not happen. The patient just wouldn't be on home dialysis. So really, we work in a very generous institution. Patients arrive for training usually 8 o'clock, and they're finished around 2 o'clock, give or take a half hour either way. And they come Monday through Friday. Occasionally, they come on Saturdays. Occasionally, that's not our general rule for hemodialysis. Again, it's dependent upon the electrical outlet and plumbing, and the training ends with a home visit. Ideally, the technician has already been to the home, so that's one home visit. The nurse then goes to the home, that's another home visit. So we have to go to the home a minimum of once a year to see the environment, to evaluate the environment of care in the home. Occasionally we take the social worker with us. We might take the dietitian with us. We might take the life child specialist with us. I don't necessarily like to go alone, but I do on many occasions go alone. Just depends on the circumstances. Oops. This is a picture of the Fresenius K-at-home machine. Very much, if you've seen the acute dialysis team at work pushing these machines, this is the smaller version of that big machine. Patients can use the soft screen at the top. It's a touch screen. It's very easy to use, but they have to be 100% able to reset the alarms, to understand exactly what they're doing. That's why training takes about 9 weeks. But I will say one thing, training really takes as long as it takes. There are no hard, fast rules here at St. Joseph Hospital. We've had some patients that might be finished in training in 4 or 5 weeks, and we've had a couple patients that maybe it's 10 or 11 weeks. But, everybody learns differently. So this is the next stage cycler, and you can see it's a much more smaller unit, also touch screen, but also has a big control unit on the bottom. Now, patients can dialyze with this machine in a hotel. They can take it with them, not the part on the bottom, but they can use bags on the top. This therapy requires 6 days a week on 5 to 6 days a week. The recommended therapy is 6 days a week, but most patients will choose to use a little bit more dialysate. They hang it up on the top like an IV bag, and they'll use a little bit more, and then they can dialyze 1 day less. But this therapy from start to finish is anywhere from, on average, about 3 hours per treatment. Takes about 15-20 minutes to set up, takes about 5 minutes to tear down. Very simple. There's a lot of waste with this. As you can imagine, a lot of plastics that aren't recyclable, a lot of cartons that get delivered to the home. There's supplies coming sometimes every 4 weeks to the patient's home. They have to have the equivalent of maybe if you have a house that's built in the late 50s, the 2-door slide closets, about one of those closets will fill all of their supplies. So can you imagine having to get rid of one of your closets in your home? Most of us would go, oh my, how could I do that? I couldn't do that. But they do it. So for peritoneal dialysis, this is the other therapy that we train for patients to be able to do in their home. There are 2 different kinds, continuous ambulatory peritoneal dialysis, or CAPD. Any of you familiar with that in the hospital? Yeah? So the CAPD are the manual exchanges. The patients will do these exchanges about 4 times a day, generally, following a pattern of 8 in the morning, 12 in noon, 4 in the afternoon, and 8 o'clock at night. Then they have their long dwell time at nighttime. We generally will teach our patients how to do CAPD for a couple reasons, but the primary reason is because we want them to be well prepared in the event of an emergency. So if something happens and patients don't have power to their home for days on end, they'll know how to use manual solution, and they can take care of themselves until electricity is restored, or et cetera. The training takes on average 5 to 10 days, and again is Monday through Friday. And the training ends with the nurse home visit. For CAPD, we don't really have to send the technical services department out because they're not using their plug yet. So we have about a month in which we can get our technical guys out there. But after about 4 to 6 weeks, patients return for additional training in the form of learning how to use the Baxter cycler. We're a Baxter exclusive, I guess, hospital, you might say. So we only use Baxter products. So now their modality changes from CAPD to APD, automated peritoneal dialysis, and you might commonly hear this as CCPD, or continuous cycling peritoneal dialysis, the same thing. So they come back for another 5 to 10 days of training, and the very first day when they come back for training, this is probably the biggest point, they have to bring in solutions, and we do what's called a peritoneal equilibration test. And this is a test that lasts about 4 to 6 hours. It requires getting various samples of solution and labs and blah, blah, blah. It's a long process for the patient, but they're here again for another six hours at the minimum. And then once this test is performed, we kind of get a snapshot, if you will, of what their peritoneal membrane, the membrane that covers the lining of the abdominal cavity, of how well that works. Is it a high transport, an average, or a low? And then we set the prescription for them to go home on peritoneal dialysis. So again, we do another home visit. So for this particular patient, the patient on peritoneal dialysis, the nurse has done at least 2. Then the technician will do another home visit for the plug. So training for our pediatric peritoneal dialysis patients is a little bit different. We follow the same pattern, except we don't start with CAPD. And the reason we don't start with CAPD is because their abdominal cavities are so tiny. We could get a 2-liter bag, and you have to look by using this. It's a fish scale. We call it the fish scale, but it's dependent upon your eyesight, and somebody could easily make a mistake and put a liter in a little abdominal cavity when only 500 was supposed to go in. So we bypass this altogether. But the training takes an average, you'll see it's a little bit longer, 8 to 10 days, depending on the age of the child. Now, a teenager, it might not take that long. But since I've been at St. Joe's, we've had at least 4, greater than, the first patient you're going to see in the pictures, about 2 weeks when we got him. We're not only taking care of the baby, but we're also taking care of mom and maybe dad or grandma or auntie. So you'll have an entourage of people that come in for training. And the first day, really, not a lot gets done, except we see how they're going to react to being put on the cycler. We see how the abdomen works, really. Training is, again, Monday through Friday, but if there is no urine output, and occasionally this is the circumstance with a child, and they have elevation in their blood pressure, which is a chronic problem for most of our brand new patients, and or their potassium levels are concerning, training may be Saturday and Sunday. And this is a challenge because lots of times we don't really know when the patients are coming. They just, they might be close to being discharged in acutes, but we think they're close, but you can imagine asking a nurse to work on a Saturday, on Thursday. We only have 5 people in our department, so sometimes it's a little bit tricky. Occasionally we have required that they are admitted to chalk for a 23-hour hold. If we can't staff it appropriately, because they can't go for that long weekend, those 2 days, without dialysis. So the last day of training ends with a nurse home visit again. And I would like to add what Pam said about our pediatric patients. These are shared patients with chalk. I think that's one of the best known secrets at St. Joseph Hospital. Firstly, that we take care of pediatric dialysis patients, but that it's a shared service. I think people think they're pediatrics, they're always automatically chalk, but there really are our patients as well. Let's see. So here's a picture of the cycler. And I don't know if you can see this right here, but there's a little spot for a data card that goes in. So the patients bring their chip in once a month for their clinic visit, and we download that chip, and that becomes a part of their permanent medical record. And that chip tells us if they skipped a day, if they skipped a couple cycles, and what their average blood pressure was for the whole month, and what their average ultrafiltration or the amount of fluid that was removed during therapy. Tony alluded to this. I think we've all alluded to this, that we couldn't do our job without our team. Well, the patient and or the care partner and the provider is at the top of the list, along with the physician, the social worker, our dietitian, the nurses, technical being our water guys and our guys that go in the home. And they're sometimes our first eyes on the scene. They'll come back and they'll say, well, Kathy, I think we're going to have a problem because blah, 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 blah. So it gives us a little bit of time within that window of training to maybe fix that problem at home. The child life specialist, she is phenomenal. I don't know if many of you know Vern Ramos, but she is a wonderful person when it comes to having to maybe draw labs on a child. She has such incredible diversion techniques that, you know, I don't know about you, but when you take care of kids, when they cry, I want to cry. I would never be able to work in chalk at all, but she's wonderful. She helps to get their attention diverted, and actually, you know, some of them come, they just run and jump in her arms. They just really develop a great relationship with Vern. Our unit secretary is invaluable to us. She, I think, gets forgotten a lot of the time, but she speaks Spanish. And on any given day, she's translating for a minimum of 1 hour. Just 2 weeks ago, 4 hours of translation nonstop with a patient in crisis. So I couldn't do my job without her. We also, I was reminded when I saw Kurt in the audience that home health provides a huge amount of support to us when our patients have peritonitis. The medications are all delivered by the home health staff, so I'm reminded, thankfully, that I'll have to add this into my slide for the next time. But the dietitians, I'd like to focus on really their role because, again, with our pediatric population, I don't think most of you, you know, you might encounter a dietitian in the hospital that takes care of adults, but our dietitians have to be able to understand completely about formulas and the different formulas that contain more potassium or more phosphorus. It's like creating well, the formula is really a medication. So they really, one of our dietitians in particular is in the process of sharing her knowledge with the others so that they can get up to speed with how we care for our pediatric patients, because most of them have a G-tube or J-tube. One of our kids has a trach, so they just don't come to us with needs of dialysis. They come to us with many, many other needs. Tony alluded to some of the regulatory requirements. I could spend another hour more on this page too. The first day the patient comes with us, we have to complete the nursing initial assessment for the first day, mandatory. The plan of care is completed within 30 days, 90 days, and annually unless the patient is unstable, and then it's monthly. Comprehensive interdisciplinary patient assessment, commonly referred to as, I think still as the CEPA, I could be wrong, but it's changed a few times. Again, the 30-day, 90-day, and annually. Monthly physician and nursing office visits. These are mandatory. When the surveyors come, the first thing they want to see is, well, how do you document what you do on a monthly basis? So we have a really good sheet now, and we use we also use clinical vision. Our charts are maybe a little bit heavier than the charts downstairs because we're not completely able to use our electronic medical record, but we do the best we can. Fall assessments. We have to assess our patients. Even though they're at home, we have to assess them for a fall. The hospital would have us, because we are surveyed differently for home dialysis services, not the chronic unit, the hospital would have us measure and monitor and record all falls, whether they occur at St. Joseph Hospital or in the patient's home. So this is quite unique for, you couldn't imagine maybe working on the floor and wondering, why does the hospital have to know that my patient fell 2 weeks ago? Well, for us, they do. We have to document, we have a very clear documentation form for home visits, for technical and nursing. Additionally, immunizations. The conditions for coverage require that we document the immunizations. So whether the patient got their immunization or their flu shot here or elsewhere, we have to document it. We have to provide a record that they've had their TB, their pneumococcal, you name it. Oxygen safety. How many of you might think that we have to document whether the patient has been informed of oxygen safety in the home? We do. So if somebody goes home on oxygen, we have to be able to provide documentation to the surveyor that we have educated that family on what the risks are of oxygen safety in the home. Medication reconciliation. Boy, we do this monthly, and at every time the patient calls on the phone, we have to ask the question, or every time we see the patient, you know, I know nurses probably think, oh my gosh, your form is really long and drawn out. I'm glad I don't have to do that. But this is equally laborious. But we really find out a lot of good information when we ask the question, have your medications changed? You see them in person, you say, oh yeah, I went to see the cardiologist and now he wants me to take this. Or a recent example of why we do this, or why it's important for us to do this, is one of our kids, during a routine visit, I said, have your medications changed? Mom hands me a prescription. This was given to her by the podiatrist. I said, oh, did you talk to Dr. Benezer and Narayan or Dr. Vega about this medication? So they'd been taking the medication already, but they still need to get approval from the nephrologist to make sure it's still okay. It's an okay dose for them to take. So, and data collection and reporting, we report a lot. A lot. Network 18, CMS, anyone that asks, we have a lot to report. We also have the document about our emergency preparedness, because and the reason we fit into this home health category is because we make more than 10 home visits per year to a patient's home environment. So I guess that's that threshold, thank you, that, well, we have about 32 patients, so automatically we do a minimum of 32 home visits per year, but we might end up doing 60 by the end of the year. So we have to document in the chart that we've talked to the patient about carbon monoxide monitors, fire extinguishers, smoke detectors. Do they have an emergency plan? Where are you going to meet? Is it going to be at the oak tree in the shopping center? Should there be a disaster occur? How are you going to get out of your home? If they're on if they have a 2-story home, do you have an emergency ladder to escape out of the second floor? We have to have documentation of all these things. And believe me, they are all part of the conditions for coverage. And the surveyor looks at every little detail. And Tony was right. The surveyor was with us for about 2.5 days. And it was one of the most stressful 2.5 days of my whole entire life, let me tell you, because I had never experienced anything like that. I mean, most of you might say hi to the surveyor in the hospital, or they might ask you a question. It was a unique experience, let's just put it that way. So our monthly care and support, we talked a lot about the monthly nursing office visit. For pediatrics, they have a monthly nursing office visit with us where we either will draw their labs, or if they're too little, we send them to Pavilion. And God bless those people in Pavilion that can draw the kids on a regular basis. And they do it so well. The last thing I want to do is to have a little 1.5-year-old and have me miss their vein, and then they start crying, and then they don't want to come and see me, and then they don't want to hug you. It's horrible. So I like to send them all to Pavilion. They're really the experts. And then they don't cry. They really do get used to it. But then we have an additional monthly clinic visit that's the 4th Tuesday of every month, rain or shine, unless it's Christmas or New Year's, with the social worker, the registered dietitian, the nurse, and the secretary. And the physician completes their physical assessment. There's a dietary assessment, psychosocial assessment. Again, the med rec, we evaluate their treatment. On that little pro card, that little data chip, we print out 3 pages generally. The doctor reviews it with the family and says, well, I see you missed a treatment here, or I see you only dialyzed for 6 hours here, your treatment time is 10. That's where all those little details are worked out. We also evaluate their supply usage, and we schedule appointments and tests for the following month. But it's a whole day event where all of our kids come. About 9 kids come between the hours of 1 to 3, and typically we don't go home till 7:30 or so. Usually Dr. Vega is still charting at 6:30. She and I are sitting there in the nurse's station. But it's quite an event. We couldn't do it without Vern, our child life specialist, who keeps these kids diverted, and she'll play games with them. She does all kinds of wonderful things with them. So, when the patients are offered the choice, many prefer to care for themselves in the comfort of their home. I've got lots of pictures to show you, and I probably have over 1,000, if not more than 1,000 photos, and this is why probably there was some confusion, because I send Tony pictures all the time of patients and whatnot, but please be assured that they've all signed their consents to be photographed, and I always ask permission before I do this. I know there's usually somebody who has that question, you know, is it okay to show a picture of a patient and to talk about them? I always get permission before I do so. So I'll share a little bit about their lives with you now. This is Marianne and her husband Paul, and you can see she has her fistula needle in her left arm. Paul is her care provider. I don't know if any of you have ever encountered Paul and Marianne in the hospital. Of course, Don has in acute services, but they've been on dialysis for as long as I've been here, so home dialysis, over probably, I'm guessing, 7 years now, because they started with a brand new machine called the Access machine. Now they're dialyzing on the next stage machine. Marianne dialyzes 5 times a week in the comfort of her bathroom. You can see she has her TV there. Paul will put her on. He'll make sure he does his documentation in a treatment record, just like you would in the hospital. And then he'll go downstairs and he'll get her a cup of tea and some cookies, and he'll come back up, and 3.5 hours later, pretty much they're all done. 5 days a week they do this. He provides her care. And it's absolutely amazing watching how he takes care of her. Absolutely amazing. We all think we're so lucky to be living where we are, doing what we're doing, but she is very lucky to have someone who cares for her like he does. They're able to travel, and this is a picture of them providing dialysis on the next stage machine out there, and she's looking out her bedroom window on a cruise ship. So with next stage, they are afforded the opportunity to travel. So traveling, though, is not as what you might think. It's an awful lot of work for Paul to navigate and to construct this, to the point where they can go and have a good time. You have to take all your solutions and everything ahead of time. You have to make sure you have everything with you. The machine only goes in the box a certain way, and you have to get permission at the ports. If you're going to put it on an airplane, you have to have letters from the hospital that it's life-saving therapy, and without therapy or without this machine, the patient will die. We use very strong language like that in our letters. Here she is looking again out the window. This is another one of our younger patients transferred to us from UCI. He's performing dialysis in his home, in his office. That's his wife Mandy behind him, and he's one I refer to Philip as our cowboy. He's the engineer he has that engineer mindset, and he's always asking questions. He'll call the company directly and ask them questions. I mean, he's really a very good home patient because he's always asking questions. Makes for a good patient. Takes very good care of himself. This is one of our adults on peritoneal dialysis who recently had a kidney transplant. The transplant failed and ended up not here at St. Joseph Hospital, somewhere else, and then has returned to the Santa Ana dialysis unit, and now has made a decision to come back to home therapy and be on peritoneal dialysis. He was on dialysis for about 5 years, not one incident of peritonitis. Again, engineer mentation, they make perfect patients for us because they're always thinking. They're always asking a little bit beyond what maybe somebody else might ask. They just make wonderful patients for us. But you can see he does all this. He's setting up, and they have to be, in their bedroom with the doors closed, the ceiling fans off, and he's just preparing. You may or may not be able to see that he has a mask on. This is one of our young kids who recently graduated last year from Anaheim High School. She and her mother were in training for almost 10 days. Didn't speak any English. Really challenging. So Edith, God bless her, was in the room with myself or one of the other nurses the whole entire time. The daughter spoke, pretty good English, but still you have to be able to touch to make sure your information is correctly relayed to mom, because mom's going to be the person who ends up signing all the documents, making the phone calls and that. This young gal was transplanted and she's in college right now, hoping to go to nursing school. So she's always, when she was with us, she talked about her desire and wants to become a nurse. So she still keeps in touch with us. This is David, and this young guy came to us when he was about, I think 2, if not 3 weeks old. Literally, I could hold him in one hand. His little butt fit right in my hand. It was my first experience ever taking care of a baby, and I was awestruck to think that, oh my gosh, it'd been forever since I'd been a nurse and working on a floor. I couldn't remember about G-tubes. I couldn't remember all these things, but I kept thinking, well, if mom's going to do this at home, I should be able to handle this, and it all worked out well. David, as you'll see in some of his other pictures, has grown up to be quite a young, nice little boy on his way to getting a transplant. But here he was in a crib that was donated to us by someone who worked in the stroke rehab department. So we didn't have the crib with us the whole time even. Now we do. We have our own little crib. But you can see he has his G-tube. He has his PD catheter that's nearly as long as he is, and his diaper, and mom's holding his head up. And here he is again in his little crib. But you can see how tired mom looks. I mean, that's not the best picture of mom, but that truly speaks to, you think, well, she has 3 other kids at home. I'm sorry, she had 2 other children at home at this time. And then has this little boy who's going to require life-saving therapy every day. I can't imagine, I can't begin to imagine what she's going through. And here we are going to have to teach her how to take care of him at home. It's amazing to me that people could even think during this time. Just amazing. And that's why it takes longer. But again, it takes as long as it takes. Now this is David, Christmas time, much older, you can see, very photogenic and always up for a picture. Mom's in much better frame. She's got her makeup on, and this was during our Christmas party. Again, Vern worked so hard to get the Christmas party going for the kids. This is with Dr. Benezer. And this is part of what we do, this is part of what we do at every clinic visit. They get measured. He can stand up. You can see he's still wearing a diaper. He still has his G-tube. When they're little, their head circumference is measured for growth, and their height almost every, I think it's quarterly now, isn't it? Quarterly, yeah. And this is on his birthday. I can't remember which birthday, the 3rd birthday, I think. And he's still small enough that he can actually sit in the scoop of the dump truck. And it couldn't walk, but could push the dump truck. So they grow up with us. It's really very touching when they take their first steps. When you see their teeth come in, it's like you have, other children. I'm a mother of one, but I feel like I'm a mother of many after working here for a long time. And mom has lost 25 pounds so that she can be the kidney donor for him. So this is Easter time. We try to make every monthly clinic has some theme. So if it's close, and this is my favorite picture. This is a picture of him and Santa, and he was so engaged in Santa's eyes. It just brought tears to my eyes, and I'm so glad I captured the moment. But this Santa also is a patient of ours who's been on dialysis for many, many, many years, who does whatever he can to help the kids always at the Christmas parties. And it's really very touching to see these. Truly, this is more like Sacred Encounter than anything you could ever imagine. It never gets documented. It's not written down. It's just in our hearts to kind of tell as we come and have these meetings. This picture's old, probably 2 years old by now. David now is on hemodialysis with Pam. The patients kind of flow between us if they have issues. They'll go back and forth and back and forth. And he's been on hemodialysis now, I think, for almost a year. Since June, yeah. But hopefully will be transplanted by mom very soon. Let me just look at my notes real quick because I want to make sure that I didn't miss anything. No, I think we're good. I had a lot of pictures of camp too. I just want to say that we also provide peritoneal dialysis services. Not like the hemodialysis services though. We usually send a nurse to go to camp, and there might be anywhere from 10 to 17 kids on peritoneal dialysis, and they have their therapy, of course, in their little cabins at night. I just want to thank you for coming to learn about the Renal Center and all the wonderful things that we provide. And And I think we missed the opportunity to thank those of you in the work in the hospital for taking good care of our patients, for our case managers, for helping the communication flow back and forth, and for the nurses to even come here today is wonderful that you're willing to take the time to come and learn about what we do, but also maybe a little bit about how we deliver our care. So it's really been a pleasure to talk to you today. Thank you very much.
Before going to the next speakers, I want to make a couple comments. When Joint Commission was here a couple years ago, what we try to do in home dialysis is because we have to do a home visit with the surveyor, and so we kind of scheme a little bit and find the most heart-wrenching little kid we can do that. So we've been successful in our last few surveys to get the surveyor crying by the time she leaves the patient's home. So figured, we'll go empathy anytime we can. The other thing I want to mention is about Vernon, our child life specialist. We've been very lucky with her, but our kids were also involved in other things. One of our little boys, Austin, submitted for the American Kidney Fund picture that he drew, and was selected for a calendar they did, and he got a trip with his mom, I think it was, to Washington D.C. to tour D.C. So it was a fun thing.